Hi guys, this is Dr. Kimberly Olson. I'm going to be sharing with you a training that I'm doing for the county on differential diagnosis. So if you're a new therapist or a therapist that's just getting frustrated, or you just want to know a little bit more about diagnosis, please stick around. I'm going to take this in segments, however, because it's quite lengthy, and I know our attention span tends to be small. So let me go ahead and start with sharing a little chart with you. We're going to talk about depressive disorders and bipolar disorders, or what we used to globally call mood disorders. So this little chart here is something I made up years ago, and you can see by its level of sophistication. But I like visuals. And in this visual, you're going to get to see really sort of the pronounced differences, although we certainly will be discussing them momentarily, between the different mood disorders. So if you look at the line in the middle, it says normal, whatever normal is. When you have major depression or you have a major depressive episode, you go from normal to the basement and then back up to normal or close to normal. Okay. So major depression is normal to the basement and back up to normal or close to normal. Now, you're going to have clients that report to you that they think they have bipolar or other mood swings because of the actual mood swing that does occur consistent with major depression. But in this case, what they're referring to is going from the basement back to normal, which certainly is a mood swing and it feels better, but it is inconsistent with bipolar disorder. Okay, dysthymia, or what us old parts call dysthymia, is now called persistent depressive disorder, what we called in grad school, and I don't know if this is appropriate, but we called it Eeyore syndrome. It's kind of melancholia. Okay. It's chronic. Got to be at least 2 years, 1 years for the babies, and low level. So just think in terms of, I almost think of it in terms of sloth, and not suggesting anything about anybody's character, but just this sort of slow, kind of moving disorder. But we will talk more. Bipolar has become sort of the catchphrase for every mood swing in our culture. Okay. And quite often it's diagnostically incorrect what's being called bipolar. So, bipolar 1 involves major depressive episodes and manic episodes. So, you go from the basement to outer space, the basement to outer space. Now, what mania or a manic episode isn't, it isn't being grumpy, it's not being ill-tempered, it's not having temper tantrums, it's not being bitchy. It's actually a set of diagnostic criteria, and it actually mirrors more someone who is on methamphetamine than someone who's just kind of grouchy, but we'll talk more in a moment. Bipolar 2, we have episodes where folks hit the basement and then they go up, but not quite to outer space. Okay. In a hypomanic episode, the symptoms are very similar, except that we're not seeing the sort of social and occupational impairment that we see with mania, or said in another way, they're not getting themselves into trouble. So let's pull up the actual training. Okay, so I'm going to skip through some of this because a lot of this I just have to have for APA. Okay, so in a nutshell, here are the summary of depressive disorder symptoms for the three most commonly confused diagnoses. Major depressive disorder, depression, sad, irritable. So just know that when someone is depressed, they may not appear sad. They might, in fact, appear irritable, especially with the babies. There's something called agitated depression. And so, what is depression for them might appear to be agitation. So, it occurs more days than not. A loss of pleasure or interest, so they don't want to, participate in sports if that was their thing, do things with the babies or whatever it was that they used to enjoy. Sleep disturbance and appetite disturbance. So what's interesting with major depression is that both sleep and appetite disturbances can go either way. You can be depressed and not want to eat, or depressed and eat everything. You can be depressed and not want to sleep, or do nothing but sleep. Now, if you've never checked out the atypical specifier for depression, please do so. Because in the atypical specifier, it is excessive sleeping, excessive eating, leaden paralysis. Take a peek at that because not everybody who is depressed presents the same way. Slowed thinking, problems in concentrating. So you can see some issues potentially with kids and the diagnosis of ADHD, which of course is marked by an inability to, of course, concentrate or focus. The thing that differentiates those two things, though, of course, would be the mood episode. They might have slower movement, feelings of guilt, and this next piece, pay particular attention to suicidal ideations. So it's not uncommon for someone with major depressive disorder to experience suicidal ideations, but have absolutely no intent. Okay. It's got something to do with being sort of down in the dumps and that natural tendency for folks to want to avoid pain. So they might think about it, but because of their religious beliefs or because they have a family, or and many other reasons people will have, they have no intentions of ever acting on it. So because someone experiences suicidal ideations, of course, that's not necessarily a reason to pick up the phone and 5150 them. You want to, of course, be looking for plan, intent, means, that sort of thing. But the reason that I really want you to pay attention to it is that suicidality isn't present in these other disorders. So if you have a client who is suicidal, you're not going to be diagnosing them with persistent depressive disorder or an adjustment disorder. Okay. Suicidality shows up under major depression. Now, some of you might be thinking, but wait a minute, Olson, there's mild to moderate. And there is, and then there's severe, and then severe with psychotic features. Well, here's the thing though. People can meet certain criteria without meeting others, but just recognize that this is the only one that says suicidal ideation or thoughts of death. Okay. So what separates it from other depressive disorders on this list? It's episodic, meaning it's not ever present. So someone is going to have a major depressive episode, then they're going to return back to normal or whatever their normal is. And it's severe, or it can be severe, meaning we're looking at suicidal ideations, things like that. Not necessarily that everyone who's depressed has that, but if they are experiencing that, just know that we don't want to be diagnosing them with some of these other forms of depression. Persistent depressive disorder, sadness, emptiness, melancholy, which, by the way, it can almost look like, amotivational syndrome. Like if somebody smokes like a lot of pot for a long time, where they got a little bit of amotivational, or I really just don't give a shit. I don't want to get up. I'm not sure I want to move from the couch. And the person may or may not subjectively experience this as depression. So there's a sort of caveat here where observed by others for 2 years or more. So maybe it's a husband or a wife that's saying, yeah, I know you're just saying that you're just lazy and you just don't care, but I think there's something else going on. Okay. In grad school, like I say, we call this Eeyore syndrome. So you want to just be kind of looking for chronic low-level depression. There's appetite disturbance and sleep disturbance, which again can go either way. They could want to sleep all the time or not sleep at all. Fatigue, low self-esteem, troubles concentrating and decision-making, and some feelings of hopelessness. So you also want to be looking at sustained life stressors there, which we'll talk about more in a minute when we get to adjustment disorders. I've seen this with people who have lost their jobs and have really struggled to gain employment because it's certainly a different world. And what started off as an adjustment disorder became sort of a persistent depressive disorder. So be taking a look at those things as well. So for differential diagnoses, it is chronic and low level compared to major depression. Remember, major depression is episodic and severe. Persistent depression is chronic and low level. What about an adjustment disorder with depressed mood? A lot of us really like this this diagnosis, I think, because it takes into account that life events can absolutely cause certain symptoms. But remember, in an adjustment disorder, there's a suggestion that these symptoms are excessive, which I'm going to be candid, I would argue. If you take a little kid and put them into foster care, whether they're acting out or they're depressed or whatever's going on for them, I think they're entitled to any reaction they might have. And I don't know that it's excessive. And besides that, excessive is just so bloody subjective. Okay. So we want to be looking at a specific stressful event, and the symptoms are emerging within 3 months of that event. Fortunately, in DSM-5-TR, there is this acknowledgement that bereavement can last much, much longer without being sort of labeled this separate diagnosis as an adjustment disorder. Bereavement in and of itself takes various forms. We've become much more sort of culturally aware. And just because someone is in bereavement doesn't mean they have an adjustment disorder. So if a person's symptoms persist longer than 6 months, then you need to add a chronic specifier. So this is an adjustment disorder with depressed mood chronic. Or, and what I highly recommend is that you start exploring alternative diagnoses. See, remember that what begins as an adjustment disorder can evolve into something else. And so we want to sort of preserve that diagnosis for something that is sort of clearly precipitated by an event or stressor. Okay. So here are the differences, guys, when you're taking that test. Remember these few little words. You don't even have to remember the whole sentence. Major depressive disorder is episodic and severe. So if in one of your little vignettes on your tests, it says that somebody's suicidal, you're not looking at an adjustment disorder or persistent depression, okay? Because remember, depression in major depressive disorder is episodic, not ever present, and can be severe. Persistent depressive disorder is chronic. So at least two years for adults and a year for the babies, and low level or lacking the severity of major depression. So again, we don't see the word suicidal in persistent depressive disorder. Know that one can have a major depressive episode imposed on persistent depressive disorder, which is really kind of sad. So we can have somebody who is depressed or really melancholy, right? With that sort of chronic low level thing. And then, oh my goodness, they're suicidal and in the basement. Okay. So both of these things can exist at the same time, or what we would call a major depressive episode imposed upon persistent depressive disorder. With an adjustment disorder, remember to look for a specific stressor within 3 months, and it's brief. Generally less than 6 months. Again, arguably, I would say if you're looking at past 6 months, you might be looking at something else, or you might need to use a chronic specifier. Okay, so obviously we're not going to do the small group activity here, but if you would like me to send you the vignettes, I would be happy to do that. So just leave your email in the comment section and I will be happy to send it, because it really, really helps, honestly. I don't know about you, but if I write it, it's permanent. Okay. If I just listen to someone like me sort of drone on about stuff, it's not going to stay as permanent as if I actually do an activity and write it down. So let me give you an example of what we are doing in those vignettes. Now, the example I selected was not related to depression because obviously I didn't want to give it away for the groups, but this example is related to eating disorders. So in the vignette, Kathy, as a 23-year-old college senior, referred to campus counseling by her physician, as Kathy was recently treated for shin splints. Kathy requests that Marcia, her roommate, attend the session with her. Marcia reports that Kathy has lost 25 pounds in the past 4 months. Marcia reports that Kelly is at the gym for 3 to 4 hours daily. Kathy states, I don't know what everyone is so worried about. At least twice a week, I will eat an entire pizza and a half-gallon of ice cream all by myself. I feel like I can't stop eating once I start. Kathy denies purging or use of laxatives. Kathy is 5'6" and weighs 125 pounds. Kathy states, I just don't want to be fat and without a boyfriend anymore. So if you were doing the diagnostic activity with us, okay, I would ask you to use your DSM-5 or DSM-5 TR to, excuse me, provide criteria for why it is that Kathy meets your diagnosis that you selected, and then provide me with that sentence or less reason that she can't possibly be suffering from this other disorder. So, for example, Kathy appears to meet DSM-5 criteria for bulimia nervosa, as evidenced by eating larger amounts in a discrete period of time than most individuals would in a similar time and circumstance. That is symptom A1 right out of the DSM. In her case, eating an entire pizza and a half gallon of ice cream. Feeling a loss of control, that's symptom A2 right out of your DSM. She feels like she can't stop herself. Inappropriate compensatory measures. So here's a little aside and trip up for a lot of people with the eating disorder diagnosis. There's like this assumption if you're bulimic that you have to be throwing up. Well, that's one form of bulimia, but it's really any inappropriate compensatory measures. So, in fact, in DSM-4, they had purge, non-purge type to differentiate those things. So purging type would be someone who vomits, uses laxatives, that kind of stuff. And then the non-purging type would be the person who does excessive exercise or fasts in between the binges. But all of these things are now under that same bulimia umbrella. Okay. Frequency of cycle at least one time per week for at least 3 months. That's symptom C. And in Kathy's case, we report twice a week for at least 4 months. Self-evaluation is unduly influenced by weight or symptom D. So she equates being lovable with being thin. And this doesn't occur during an episode of anorexia. So she's a normal BMI. So she can't be anorexic. So remember, that's one of sort of the red flags that a person does not have anorexia, is that we have to be talking about an abnormally low BMI. Back in DSM-4, they would say 80%, less than 80% of expected body weight. But we got a little bit more sophisticated and we don't go by that. We go much more by BMI now. And by the way, most bulimics are of normal weight or slightly overweight. Okay. And continue to exercise despite injury. So we definitely have a problem here. She's experiencing impairment and continuing to do what she's doing. So we see physical and social impairment. So then the next portion, you'll rule it out. Okay. Kathy does not appear to meet criteria for anorexia for the reason I just shared with you. And see, it's in a sentence or less because she's normal BMI. So she doesn't have anorexia. She might be skinny, but if she's of normal BMI, she's not going to meet criteria for anorexia nervosa. And guys, don't forget that there's like eating disorder specified and unspecified. Okay. Because we don't want to like not treat somebody because they don't quite meet that criteria yet. God, we want to get on that right away. But that's where our specified and unspecified diagnosis has been in. Kathy also does not appear to meet criteria for binge eating disorder. While she does binge eat, she uses inappropriate compensatory measures consistent with bulimia. So if you were taking a test, okay, you would know that she can't be anorexic because she's normal weight, and that she can't have binge eating disorder because she uses purging or inappropriate compensatory measures. Okay, so we looked at the mood disorder table. So the second one and the final one we're going to go through on this video is bipolar and other mood disorders. Now, I know that the DSM has broken this up into, there's like depressive disorders and there's bipolar disorders. And in DSM-4, that was all under one category, which was mood disorders. And they're so closely related, I can sort of see the argument for categorizing things either way. Well, I was talking with you earlier about a manic episode and what that really is. It's increased energy, inflated self-esteem, decreased need for sleep. Person is usually very talkative, have pressured speech, flight of ideas or racing thoughts. They're highly distractible, increase in goal-directed activity, and excessive involvement in activities that have a high potential for painful consequences. So, think in terms, and again, this is the best example. I've seen people who are manic, I've seen people who are on methamphetamine, and it's really close. Okay. So manic folks will, they become grandiose or that inflated self-esteem. So they might be doing things like calling you at 2 in the morning and trying to convince you to sell Amway, because right now their self-esteem is very high and they're very grandiose and they haven't slept for 3 days. And so I believe that if I buy $5,000 worth of Amway right now, I will have it all sold before my wife or husband even sees the charge on the credit card. Okay. That makes perfect sense to you when you're in a manic episode. Okay. I want to go to Las Vegas and I feel like I am especially blessed. I feel the blessings of God all over me. And so I have no problem taking money from the savings and playing it in Vegas. I think that I've fallen in love with this person that I have just met because there's some special aura between us, right? You just met it, but that's what you believe in the morning, in the moment. And so you end up doing things that get you in trouble. Okay. That is one of the key features of mania versus hypomania, is that when you're in a manic episode, you tend to get yourself in trouble. Okay. But here's the other part. The episode must last 7 days at least. So somebody who is just really moody, or you say something to them and they just blow up, okay, we're probably not looking at bipolar. We might be looking at intermittent explosive disorder or some other diagnosis. Okay. But this episode must last at least 7 days and create social or occupational impairment. So that means at least a week, and you got to get yourself into trouble in some way. Hypomanic episode, if you look at the diagnostic symptoms in the DSM, they're exactly the same. And you might be scratching your head and going, excuse me. Well, here's the difference. The episode must last at least 4 days, which is different from mania, which is 7 days. And it does not cause social or occupational impairment. So you're not getting yourself in trouble. People might be looking at you like you're a little weird or something. But people who have hypomanic episodes tend to enjoy them. They can maybe get a bunch of housework done that they haven't done before. They're up all night writing papers. They feel incredibly productive and are kind of bummed out when the crash occurs. So that's hypomania. Note that, however, impairment can occur during the major depressive episode. Okay. So when we're talking about the differences, manic, 7 days, impairment, hypomanic, at least 4 days, no impairment during that episode. Bipolar 1, you got to meet criteria for at least one major depressive episode and at least one manic episode. For bipolar 2, you have to meet criteria for at least one major depressive episode and at least one hypomanic episode. So you can be bipolar 1 and experience a hypomanic episode. Just know that. So it would be bipolar 1, most recent episode is hypomanic. The key is, in order to have the bipolar 1 diagnosis, you have to have had at least one manic episode. Okay. So what about the other moodiness stuff? Okay. There's something called cyclothymic disorder, and that's where somebody is up, but their symptoms don't really meet criteria for hypomania. And they get kind of down, but their symptoms don't meet criteria for major depression. At least 2 years with symptoms occurring at least half of the time. So you're just kind of moody. Okay. You're depressed, and then sometimes you get up, but you're not really meeting criteria for the bipolar disorders. 1 year for kids, and periods of stability during that 2 year period last less than 2 months. So again, we might call this cyclothymic disorder bipolar light. Okay. But there's a bunch of mood disturbances, guys, right? For all the things that we label bipolar, and in fact, they're probably something else. Bipolar, again, has become this catch-all phrase for being moody. One of the things that we see with a degree of frequency is bipolar disorder and borderline personality disorder, mistakes in differential diagnosis. Now, there's a couple of reasons for that. Number one, you can have both. But number two, psychiatrists have to prescribe to a diagnosis. And bipolar 1 is a primary diagnosis, and you're going to get some sort of bipolar cocktail from the psychiatrist that Usually involves a mood stabilizer, an antidepressant after your mood's been stabilized. Otherwise, it'll throw you into a manic episode, and an antipsychotic if appropriate, because some people have psychosis when they have mania. It's the only time they have psychosis, but they do have it. And so, if you're treating somebody with borderline personality disorder who has these mood swings, you may still use that same type of cocktail to treat them. Because, guys, we don't know exactly how much is neuro and what isn't, when it comes to certain mood disturbances. But we do know that the treatment, in the case of pharmaceutical treatment, is going to be the same. Therapy treatment, we're looking at some differences, although dialectical behavioral therapy and working with those mood fluctuations would probably help both. So, how do you know that it's borderline? The person's mood swings are generally triggered by some negative interpersonal exchange or perceived threat of abandonment. So, we are going to, in a later lecture based on this, going to be talking more about that. I mean, about how uh, sometimes when you have like that sunburn, as Lenahan would say, anything that brushes across your skin hurts. Okay, so you might say or do something and you don't understand why it's triggering to this person with borderline, but all of a sudden you go from having a pleasant afternoon to somebody screaming, and you're going, "What the hell is going on?" Okay, so you're going to know that it's different from bipolar, right? Which, I mean, it could be just Saturday and the sun is shining and you've got a manic episode on your hands. Whereas with borderline, it is absolutely predicted or preceded by some type of negative interpersonal exchange or perception of a negative interpersonal exchange. Premenstrual disorder is triggered by hormonal changes. So, guys, thank your lucky stars that you only have your mood swings God, it's twice a year you guys go through a full hormonal cycle. Ladies, every 28 days, and I'm sure that was no surprise. And so, when your hormones are whacked, you're going to have wacky mood. Okay, that's just part of the deal. And then I was going to say finally, but it's really not finally, but it's super important. Impulse control disorders. So we have something going on societally where we have like lost our manners. Obviously, with impulse control disorders, for certain people, there's neurological components. But what I want to share with you is that if you could slow your roll, not get enraged, and not be a jerk, if someone you respected walked into the room, you have control. But sometimes we give ourselves permission. Maybe we feel entitled. Oh, you made me so mad, so I'm just going to lash out at you. I wouldn't have done that to you if you hadn't done A, B, and C. You're culpable and responsible for your own reactions to things. And unfortunately, we have become a society with very little impulse control. Okay, and you see it online, right? Where folks will just get really volatile and personal and gross with you over something that I don't know, it was rage waiting to happen. They were looking for some reason and some sort of justification to lash out, and they've given themselves permission to lash out. Again, maybe even feel entitled to lash out. You know, it's kind of like those unfortunate posts that I read where it's like, if you can't handle who I am, I don't care. And somebody thinks they're being, flippant and cool. When the truth is, you're just kind of saying I'm a narcissist and I don't care about other people's feelings. So we want to look for impulse control issues as well. And here's the take home test, guys. If you could control it when someone you respect and you want to like them walks in the room, you could control it with your wife or your husband or your kids. But you, somewhere down the road, gave yourself permission to act out. And then substance-induced mood disturbances. So everybody's jacked on caffeine. Okay, which means that we're much more quick to temper, much more moody. And of course, if you're on any type of stimulant medications, or on methamphetamine, things like that, you're going to have severe mood disturbances. And then we've got the functional heroin who are going to nod out 1 minute and then they might be dope sick because they're not able to get it. That's a mood disturbance. Or medically induced mood disturbances. Obviously, if you're in pain, you're going to be moody. You're going to have feelings about that. So how do we do differential diagnoses with these? Okay, for the big guns, first of all, a manic episode at least 7 days causes functional impairment. So you're in there taking that exam where they're asking you about diagnoses. If that person hasn't had that manic episode for at least 7 days and it doesn't cause functional impairment, you're not looking at mania. For hypomania, at least 4 days, and it does not cause significant impairment. That's the hypomanic episode. Again, they can experience impairment during the depressive episode. So bipolar 1, we have at least one depressive episode, one manic episode. Bipolar 2, they have at least one major depressive episode and at least one hypomanic episode. In cyclothymia or cyclothymic disorder, we're looking at mood fluctuations that do not meet full criteria for major depression or hypomania. So we've got somebody who's just experiencing some mood swings, but those mood swings have sort of a resemblance to depression and hypomania. It's just not as severe. They're not meeting full criteria. Okay, so that's where we would have another small group activity. In the next video, I'm going to start with anxiety disorders. Then we're going to do psychotic disorders. And then in the final video, we will end with cluster B personality disorders, which are often, again, misunderstood, misdiagnosed, because there's such a crossover. So we will learn about how to distinguish those in a sentence. So I really hope that you got something out of this video and that it helps you on your exam or it helps you in practice. And I will see you again soon. Thank you so much.